All right, just a couple of announcements before we begin the afternoon session. First of all, we know that it was very cold in here this morning, but as part of our MS comprehensive care team, we've had our thermoregulators speaking to the authorities, and I think it's actually already warmed up in here a bit. So we did hear your pleas. I want to remind you again, please, in your blue packets that you received, there is an evaluation program specifically about this day's symposium. We would be very grateful if you would fill it out, give it to anybody with a yellow shirt, or leave it on your table, or take it to the registration desk at the end. It will really help us for future programs. Now, we think that at the Corinne Goldsmith Dickinson Center for MS, we have a lot of talent, and we like to showcase that talent in this symposium. But we definitely don't have all the answers nor all the talent, and the MS world is blessed with a lot of really dedicated investigators and clinicians. And I'm very honored to be able to introduce you now to someone who's really a giant in the field of MS therapeutics. And Dr. Jeffrey Cohen, our guest speaker, is a professor of medicine at the Cleveland Clinic Lerner College of Medicine. And Jeff is the director of the Experimental Therapeutics program at the Mellen Center for MS Treatment and Research in Cleveland. The Mellen Center is one of the very foremost centers for MS research and treatment in the entire world. Dr. Cohen received his BA degree from Connecticut College and his medical degree from the University of Chicago School of Medicine, and then did his neurology residency and a postdoctoral fellowship in neuroimmunology at the University of Pennsylvania. He's been at the Mellen Center since 1994, and as I said, he's now director of the Experimental Therapeutics program, and also runs the Clinical Neuroimmunology Fellowship and the MS Academic Coordinating Center. Dr. Cohen has been involved in innumerable clinical trials and is widely recognized throughout the world for his leadership in that particular aspect of MS, but he's also a practicing MS physician who spends much of his time taking care of people. This morning we talked a little bit about CCSVI and the kind of science that's needed to investigate that. Another area that has seen lots of hype in the MS therapeutics arena is the issue of stem cell therapy. And I think we've asked Dr. Cohen to address that subject, and I think you're going to see that he brings with him not only a message of hope about MS therapeutics, but also the scientific rigor that's needed to investigate these subjects closely. So please give a warm welcome to Dr. Jeffrey Cohen.
Well, good afternoon. So Aaron, first of all, thanks for inviting me to give this talk and for the very nice introduction. Also, thank you for having me follow Zoe Koplowitz. Her inspirational talk is going to be a tough act to follow. So when I'm seeing patients in the office, I would say there's four things that they ask me most often about. First of all, when is there going to be a pill for MS? Dr. Lublin's going to fill us in on where that stands. Second of all, what about this CCSVI? Dr. Miller updated you on that. Third, what do I think about LeBron James, or as we know him in Cleveland, he whose name must not be spoken. And that I refuse to discuss. And then fourth, where do things stand with stem cells? So that's what I'm going to review for you this afternoon. So my disclosures are listed here. Basically, I don't have any disclosures that are relevant to this talk. So let's start with an overview of what I'm going to cover today. So that's presented here. First of all, I'm going to talk about two different ways in which stem cells are talked about in multiple sclerosis. One is so-called immunoablation and reconstitution. I'll explain what that means in a minute. And then secondly, stem cells to repair the damaged nervous system. And I'll talk a little bit at least about all of these, embryonic stem cells, neural stem cells, so-called induced pluripotent stem cells, and then finally mesenchymal stem cells. So let's begin by reviewing what a stem cell is. So the definition of a stem cell, what it means to a biologist, is outlined here. So these stem cells are primitive cells that have three capabilities. First of all, they're the ability to self-renew, in other words, the ability to divide and replenish their supply. Secondly, they are what's so-called pluripotent, which means they're capable of developing into all the various cells in a tissue. And third, they have the capability of reforming a tissue. So that's what a biologist means when they say stem cell. So what are the ways that a stem cell might be of benefit in multiple sclerosis? So you heard these concepts already in earlier talks. There's three potential aspects of MS that stem cells could be of use. First of all, so on the left-hand side of the slide is a vein from the brain of someone with multiple sclerosis, showing those dark circles. Those are lymphocytes, the immune cells that have abnormally accumulated within the tissue. This is the inflammation that causes damage in multiple sclerosis. The middle panel shows the kind of damage that occurs. So those two lines that go across the screen that are alternating green and orange, that shows two nerve axons, two nerve wires that have had their insulation, their myelin, stripped. And then the line at the top of that panel, which ends in a ball, is an axon, a nerve wire that's been cut because of the inflammation in multiple sclerosis. And then on the right-hand side of the slide, that shows precursor cells, cells that are normally present within the brain that accumulate in MS lesions and that are attempting to repair the damage. So all three of these processes potentially are aspects of MS that stem cells could be of use for. So let's talk about the first way that stem cells are discussed in multiple sclerosis, so-called immunoablation and reconstitution. So this slide shows a cartoon that illustrates the process of this sort of treatment, so-called rebooting the immune system. So if you start in the upper left-hand corner, one administers medications to the patient that then produces their bone marrow, the liquid inside the bone where the blood cells come from, to produce so-called hematopoietic stem cells. These are the stem cells that give rise to the blood cells, including the immune cells. And then those stem cells are collected, that's in the middle panel, and then the immune system is destroyed, either with potent chemotherapy, monoclonal antibodies such as alemtuzumab or Campath, one of the treatments that's being tested in multiple sclerosis, or total body irradiation. The purpose of that is to then wipe out the immune system. And then one either just waits for the immune system to regrow or readministers the hematopoietic stem cells. That's the lower left-hand corner. During that time, until the immune system regrows, the person is without an immune system. And then finally, in the lower right-hand corner, the immune system is regrown and the person has recovered. So why might someone undergo this approach? Well, so the idea is that the immune system in multiple sclerosis has made a mistake, developed abnormal inflammation. That's what leads to the damage in multiple sclerosis. So the idea is to remove that autoreactive immune system and replace it with a new immune system that hopefully will recover normally and will not make the same mistake the next time. So there's two aspects of this. One is the immunoablation. That's the wiping out of the immune system. So that in and of itself may be of benefit because it's a very potent immune therapy. It's in fact our most potent immune therapy. And then the second part is the reconstitution. That's the regrowing of the immune system. Hopefully this time that will not make the same mistake it made last time. So as you would expect, this is a fairly aggressive, fairly harsh therapy. And so the kinds of complications that can arise, first of all, the chemotherapy frequently has side effects. And people sometimes, in fact, experience an MS relapse during the time that they're getting the conditioning and the immune therapy. And then during the period in which their immune system has not recovered, they're prone to infections. So that's why this sort of therapy isn't undertaken in everybody, because it sometimes is dangerous. So there was up until recently, most of the studies of immunoablation and reconstitution used very aggressive protocols and were largely reserved for people with very severe MS, people whose MS had not responded to all the other therapies. As a result, there were a fair number of complications, and the results were somewhat disappointing. So this article from Dr. Burt and his colleagues at Northwestern raised a lot of excitement. So I'm not going to go through the details of this, but just to say that what was different about this particular study was that they used a somewhat less aggressive immune therapy approach, so it was safer, it had fewer side effects. And secondly, that they studied people at earlier stages of MS, people whose MS still had a fair amount of inflammatory activity. They were still having relapses. Their MRIs were still active. And in a nutshell, the reason why these studies led to a lot of excitement is that people tolerated this procedure much better, and there was much more convincing evidence of benefit. Relapses essentially stopped after people underwent this procedure. So who are the people that are most likely to benefit from hematopoietic stem cell transplant, or so-called immunoablation and reconstitution? So as we saw in the study from Dr. Burt and his colleagues, these are people that are young, whose MS is relatively recent in onset, whose MS has not yet gotten too severe, who still have a lot of inflammatory activity, relapses, lesions developing on their MRI scan, but who have continued to have activity despite the other more standard therapies. So there's now a lot of interest in pursuing this further. A collaborative group has been set up to further study this. So we look forward in the next couple years to seeing where the place is for this therapy. All right, so let's now turn to the other reason why people are excited about the potential of stem cells in multiple sclerosis, specifically their ability to repair the damaged nervous system. And in this context, 4 kinds of stem cells have been talked about, and I'm going to go through these now. So to do that, let me just show you very briefly the different types of stem cells that people talk about. So this slide shows the development, the maturation, starting with so-called embryonic stem cells. So if you think about it, the fertilized egg and the embryo that has just a few cells in it that develops from that really are sort of the ultimate stem cell. It's from those cells that all the rest of our body develops. So the first type of stem cell that has been talked about is embryonic stem cells. As the embryo is developing, those stem cells develop into other tissues, they migrate into those tissues, they divide to supply cells for those tissues, and then they become committed to developing into one type of cell or another. So those are the so-called progenitor cells and the so-called precursor cells. So these are cells that are going to divide and develop into a nerve cell, or going to divide and develop into a skin cell. Once a cell starts going along a certain pathway, it's easier for it to proceed in that direction, but it loses some of its diversity, some of its ability to develop into other things. And then finally, in the adult, there are the fully developed cells. So these are our hair cells, our skin cells, our nerve cells. So those are the differentiated cells at the bottom. The other thing that we've learned recently is that there are, in fact, stem cells present in the adult. So that's that little detour off to the left. It turns out that all of the tissues in the body continue to have stem cells up into adulthood because all of our tissues wear out. There needs to be a supply of cells to repair them. So let's talk a little bit about the pros and cons of embryonic stem cell. This is one type of stem cell that's gotten a lot of publicity. So these are cells that are derived, that are isolated from a very early embryo. Their advantages are, because they're the most primitive stem cells that are available, they have an indefinite capacity to regenerate themselves, to divide, and they have the ultimate potential. They can develop potentially into any type of tissue in the body. Their disadvantages are, first and foremost, that there are a lot of practical and ethical concerns with isolating embryonic stem cells. And I'm not going to go into the pros and cons of that, but I think those issues are well known to you. And more importantly, we really don't know, even though there's been a lot of promise talked about with these sorts of stem cells, we really don't know yet how best to use them. And in particular, we don't yet know how to how to encourage them to develop into the tissues that we...
1, 2.
That's not me, by the way.
Check, check.
Could whoever's doing that please stop?
Check. Check.
So we don't yet know how to direct them to develop into the tissue we're trying to repair and to not develop into the incorrect tissue. How do we stop these cells from turning into a tooth inside the heart? The second kind of stem cell that's talked about are so-called neurostem cells. So one example of that would be these embryonic tissue-specific stem cells. So these are cells, stem cells within the nervous system whose job it is to replenish the nerves. These are present both in the developing embryo, but they're also present in the adult brain. So the advantages, the source of these would be either, you would isolate them either from a developing embryo, the parts that are going to develop into the nervous system, from a fetus, or potentially from one's own adult brain. The advantages are that these are cells that are already committed to developing into nervous tissue, so one would expect that it would be easier to get them to finish the job. On the other hand, as you would also probably imagine, there's substantial practical and ethical issues with these cells too. The third type of stem cell would be that has gotten a lot of attention recently, has generated a great deal of excitement, are stem cells derived from already developed cells, cells from an adult that are easy to obtain, for example, skin cells. So these are the so-called induced pluripotent stem cells, or iPSCs. So these are cells that are isolated from adult tissue, for example, from a skin biopsy. Then using molecular techniques, they're stimulated to de-differentiate, to develop backwards into a stem cell from an adult cell. And then using other molecular techniques, encouraged to develop back along some pathway. So go from a skin cell back to a stem cell and then into a nerve cell. So I would say in the stem cell field, there's an extraordinary amount of excitement about this particular type of stem cell because they're easy to, in theory, easy to obtain. And once we learn how to guide them to develop into the appropriate pathway, should be very useful. At the moment, we don't yet know how to do all those things in a way that's clinically safe. So this is something that's still very exciting in the lab. That's exciting. It's mostly something that's being done in the laboratory. The other potential disadvantage of all of those stem cells that I just talked about is that they mostly just address the aspect of MS that's outlined on the right-hand side of this slide. Their main job is to replace the damaged tissue by, in fact, developing into the cells of the nervous system. And they, as far as we know, would not be expected to have very potent anti-inflammatory effects, one very important aspect of multiple sclerosis, and would not be able to protect the nervous system from the damage that occurs from the disease. So the last kind of stem cell that I'm going to talk about today are mesenchymal stem cells. And one of the reasons why there's so much excitement about these potential cells is that there are aspects of them that we think may address all three of those aspects of multiple sclerosis. The other reason why I want to highlight them today is that this particular type of stem cell is something that's moving into the clinic. There are a number of clinical trials of this particular type of stem cell, including trials in multiple sclerosis that are either underway or about to get started, and we're in fact one of the sites that's going to be doing that. So what are these mesenchymal stem cells? So if you remember, earlier in my talk I said that in the bone marrow, the liquid in the center of the bones are the hematopoietic stem cells. These are the stem cells that ultimately give rise to the blood cells, the red blood cells, the white blood cells, including the immune cells. But there's a second kind of stem cell within the bone marrow, the so-called mesenchymal stem cells. One of their jobs is to develop into the support structure of the bone marrow. So they create the support that allows the blood cells to develop. But these mesenchymal stem cells also develop into other supporting tissues in the body, muscles, bone, skin. And it turns out that in addition to that, they also have a variety of immune effects and a variety of reparative effects that make them an exciting potential treatment for diseases such as multiple sclerosis. Now, this particular kind of stem cell not only is present in the bone marrow, but they're also present in a number of other tissues, including fat. So although we know the most about bone marrow-derived mesenchymal stem cells, and the stem cells that we'll be using in our trial will come from the bone marrow, there also is a lot of work recently on mesenchymal stem cells derived from fat. So what I expect in the future is not only will you have a stem cell transplant, but you also can have liposuction. So get double bang for your buck. So what do these mesenchymal stem cells look like? So they have a number of properties that allow us to isolate them from the other cells in the bone marrow and grow them up in culture into large amounts to make them a usable therapy. So if you look at the four pictures on the right, the picture in the middle, in the upper left-hand corner labeled B, that's what these cells look like under the microscope. So one of their properties that's very useful is that when you culture them in the lab, they stick to the plastic dishes, whereas the hematopoietic stem cells float away. So within a few days, you have a pure culture of these stem cells, and you can remove the other cells. The second way that we characterize them are the other three pictures. So these are pictures of their ability to develop into bone, their ability to develop into cartilage, and their ability to develop into fat cells. So that's the second way that we clarify that we have isolated the cells that we intend to. And then those graphs on the left-hand side of the slide show that immunologically we can characterize these cells, and they have very characteristic molecules that they express and very characteristic molecules that they don't express. So all of these properties allow us to grow them up in the laboratory to purity. So as I said, these cells have a number of properties that make them very enticing as a potential therapy for multiple sclerosis. So first of all, they were first discovered by their ability to treat what's called graft versus host disease. So when someone undergoes a bone marrow transplant, for example, as part of cancer therapy, if they receive the bone marrow transplant from another person, one potential devastating complication of that is what's called graft versus host disease. In other words, the transplanted bone marrow creates an immune reaction against the recipient's body. And it's typically a devastating complication. But in an attempt to improve engraftment, giving mesenchymal stem cells along with the bone marrow transplant, it was noted that not only did it improve the ability of the bone marrow transplant to take, but in fact very potently inhibited graft versus host disease. So this was the first clue that these cells have very potent immune effects. So subsequent work led to characterization of those effects and showed that mesenchymal stem cells have a variety of immune effects, many of which one would think would be of benefit based on our understanding of the immune abnormalities in multiple sclerosis. A second property of these cells is that, as I said earlier, they're present in all the tissues of the body. And One of the roles that they're thought to have is to protect those tissues from an overexuberant inflammatory response. So if one gets an infection in your skin, the immune system needs to establish inflammation to fight the infection, but one doesn't want the immune system to go crazy and cause excessive damage. And it's thought now that one of the cells that keeps the immune system from going berserk is mesenchymal stem cells. So they potentially may have the ability to protect the nervous system from the abnormal inflammation that occurs in multiple sclerosis. And then finally, in addition to the ability to differentiate, to develop into bone, skin, muscle, that sort of thing, these cells also have at least limited capacity to develop into other cells, including nerve cells, oligodendrocytes, the cells that develop into myelin, astrocytes, the support cells in the nervous system. So, and they have the ability to migrate from the blood into areas of damage, including the nervous system, and potentially turn into the cells of the tissue. But more importantly, then we think that, because we think that may be mostly sort of a quirk of the laboratory, is that what these cells really have the ability to do is to create an environment that encourages the natural repair mechanisms. And why do we think that's important? So that's shown here. So on the left-hand side of the slide is a long-standing multiple sclerosis lesion, and all those little brown shapes are the naturally occurring repair cells within the nervous system, showing that there are plenty of neural stem cells in MS lesions. And then if you look on the right-hand side of the slide, that's an oligodendrocyte in a myelin-forming cell within an MS lesion trying to form myelin. So you see it's sending out these processes to those green lines across the slide. Those are the nerve fibers. It's sending out processes trying to remyelinate. So there's plenty of cells that are there potentially to remyelinate, and there's cells that are attempting to remyelinate, but something interferes with the process. So the hope is that the ability of mesenchymal stem cells to create a more encouraging environment will augment these naturally occurring processes. So I don't expect you can read this table and the next table, but what these two slides list are all the published studies so far that have occurred using mesenchymal stem cells. And in total, there's about now 500 to 600 people that have received mesenchymal stem cells for a variety of conditions that in the published literature. By far, the most common conditions that have been treated with mesenchymal stem cells include graft versus host disease. That's that devastating immune complication of bone marrow transplant that I told you about before. They're now one of the first-line therapies for graft versus host disease. And the second indication that these cells have been tested in is in acute myocardial infarction, acute MI, because of their ability, when they're squirted into the coronary arteries, to find the damaged area of heart and repair the damage. They've also been looked at in a variety of other conditions, a variety of other disorders where there's tissue damage and failure of repair, and included in those are spinal cord injury, amyotrophic lateral sclerosis, stroke, neurologic disorders. Overall, I would say in summary that these studies have shown that these cells, when administered intravenously, are very well tolerated. There have been very few, if any, complications. And at least in some of these reports, there have been very dramatic benefits shown. However, the overall number of reported recipients of these cells still is quite few, so that as we started to develop our studies in multiple sclerosis, the FDA dictated we take a very cautious approach, and I'll describe our study in a minute. But there are already several small reports in multiple sclerosis of these cells. As you see in the second column from the right, the number of people with multiple sclerosis that have received these cells from these investigators still is quite small, but in general, the experience has been very encouraging. It's appeared to be safe, and there's been some indication of benefit. So that experience then led to this conference that was held now about a year and a half ago in Paris that included a variety of people with experience using mesenchymal stem cells for other indications, hematologists, for example, experts in the immunology of multiple sclerosis, and experts in running clinical trials in MS to try to move the field along to pursue mesenchymal stem cells as a potential therapy for MS. And so what we did was review what the previous experience with mesenchymal stem cells, their biology, the rationale for using them in multiple sclerosis, and then began to design the kind of studies that we would need to do to pin down whether these cells are in fact safe and useful in MS. So at about that same time, I had already set up a collaboration with investigators at the National Center for Regenerative Medicine, a group on the Case Western campus, who actually already had sizable experience in using these cells in other indications. So they've isolated these cells from now over 500 people, and they've used them to test, to look for benefit in several indications, including graft versus host disease, recovery from bone marrow transplant, and in several metabolic diseases. So we thought we would pool their expertise in mesenchymal stem cells and our experience in MS clinical trials to pursue these cells in MS. So let me just spend the last couple minutes describing the study that we're about to undertake. Hopefully we'll start enrolling people in the next month or two. So the study is funded by, the trial itself is funded by the Defense Department. That may strike you as being somewhat odd, but it turns out that the Defense Department does in fact fund a substantial amount of medical research, as you would expect, mostly research that would be of interest to them. So regenerative research would be one of those things to try to repair injury from battlefield injuries, for example. We'll also be doing fairly extensive immunologic studies as part of the trial, and those studies will be funded by NIH. The trial is going to be relatively small. Overall, we're going to enroll 24 people, about half with relapsing remitting MS, about half with progressive MS, with moderate to severe disability, a requirement for some activity in the disease in the 2 years prior to the trial. And the treatment will include a single intravenous infusion of a certain dose of what are called autologous culture-expanded mesenchymal stem cells. In other words, we're going to isolate stem cells from the patients themselves, from their bone marrow, grow them in the laboratory, and then inject them back into the patient. And then we'll be monitoring them fairly intensively for 6 months. So this shows the structure of the study, and I just want to make a couple of points from this. I'm not going to go through this in detail, but I just want to point out what a large endeavor, even a relatively small trial like the one I just described, turns out to be. So we have a steering committee that includes experts in stem cells, experts in trial, our statistician. We get input from an advisory committee that includes radiologists, stem cell biologists, neurologists. We have a separate committee, a so-called data safety monitoring committee, whose job it is to sit outside the study, have access to all the data, make sure that we stay on our toes, that things are being done safely. Patients will be enrolled from the patients that we follow at the Mellen Center, and then will be followed at the Mellen Center. We'll administer the cells, perform the examinations, keep track of side effects, do the MRI scans. The cells will be grown in the Center for Stem Cell Regenerative Medicine on the Case Western Reserve campus. The MRIs will be evaluated at our place. The cells will be evaluated over at Case. And then finally, a big undertaking, even for a small study like this, is managing the data, keeping track of all the numbers that this sort of study generates. So our primary purpose in this study will be to make sure that it's feasible to do this sort of study and to look very closely at whether it's safe. We'll be focusing initially on safety in the first month, make sure that the infusion itself is safe, but then we'll be looking more carefully at safety over the subsequent 5 months. We'll also be looking for any indication of whether the transplantation is beneficial, whether it either has benefit on reducing disease activity or whether there's some indication that it's led to repair of damage of the nervous system. So you might ask, why are we taking such a timid, cautious approach when, as I showed you, these cells have been studied in a whole variety of conditions? Well, as we started our discussions with the FDA to undertake this study, I think they took a very appropriate view that this is a new therapy. As far as I know, this is the only funded trial of mesenchymal stem cells in North America. So they were sort of wary of this, wanted to make sure that we proved this was safe, so that then we could go full bore into a larger, more definitive trial. So we're going to focus on several potential complications that we hope won't happen, but we're going to be watching very carefully for them. So first of all, whether the infusion itself causes any problems. Secondly, whether people get infected, either from the cells themselves getting infected during culture, or whether the immune effects make someone prone to infection. Then we'll be looking for two conceptual potential complications. One is whether people develop cancer. So if you think about it, a stem cell is very similar to a cancer cell. It divides, and it divides abnormally, and it can develop into abnormal cells in the wrong tissue. So we'll be looking to see whether there's any indication of cancer. And then we'll also be looking to see whether there's what's called ectopic tissue formation, whether cells go into one tissue and develop into the wrong tissue. They develop muscle in their skin, that sort of thing. And then finally, one of the things we'll be watching for very carefully is whether instead of being beneficial, these cells in fact make the disease worse. There have been a number of examples of potential treatments for MS that seem like a good idea, but in fact didn't work or in fact made the disease more active. And so that's one of the things we'll be looking very carefully for. A very important aspect of the trial will be to study the immune effects of these cells. That's going to be done in collaboration with Dr. Amit Bar-Or at Montreal Neurologic Institute. And the reason why that's very important is shown here. So we've already started undertaking some preliminary immunologic studies. I'm not going to go through these pictures in detail, but just to show that what this study showed, which was published now a couple of months ago, is that as expected in the test tube, these cells suppressed certain aspects of immune function that one would think would be of benefit in multiple sclerosis, but somewhat unexpectedly encouraged other aspects of immune function that might in fact make MS worse. So we don't know whether this is going to happen in people, but it just illustrates why we're taking a very cautious approach, because unexpected things can happen. So that's sort of an overview of where things stand with stem cells. Many of us are very excited about them, but there are a number of potential issues that we're going to have to be wary about. So first of all, ultimately, to treat MS effectively, we have to combine anti-inflammatory, protective, and repair strategies. How we administer the stem cells will have to address the fact that, as you heard in the first talk today, MS involves multiple lesions. Lesions spread out throughout the nervous system from your brain all the way down to the tip of your spinal cord. We're going to have to administer the cells in a way that gets to all those areas of damage. We also have to recognize the fact that MS is a chronic disease. It's a disease that develops over decades. It's unlikely that a single stem cell administration is going to last forever. We have to recognize the fact that we can't just get the cells into the body and expect them to recreate the nervous system. It would be like dropping your TV on the floor and then throwing some transistors in there and hoping that that would repair it. We have to somehow rewire things appropriately. We also have to be prepared for the fact that there may be something about the immune system in MS or the nervous system in MS or our MS therapies that's inhospitable to stem cells. So we're going to have to take that into account. And there's finally the possibility that stem cells from people with MS may be defective in some way. That may be part of the reason why people with MS don't effectively repair their nervous system. So it may turn out that in the future we're using stem cells from other people. All right, so in conclusion, I've talked about several different kinds of stem cell transplant and multiple sclerosis. The first one, so-called immunoablation and reconstitution, so-called rebooting the immune system. There's substantial experience with bone marrow transplant in general and increasing experience in MS in particular. The ultimate trade-off between the potential risks of this approach and the potential benefits still remains to be determined. There's a lot of excitement in the scientific world about embryonic, neural, inducible pluripotent stem cells. At this point, they're not really ready for prime time. And then finally, one particular kind of stem cell, mesenchymal stem cell, is ready for prime time. And in fact, we and a number of other groups are beginning studies of them. So hopefully over the next few years, you're going to see this field taking off. Thank you.
Well, thanks, Jeff, for showing us a very novel and exciting avenue in MS therapeutics, but at the same time emphasizing to the entire audience how complex it is to study a novel form of therapy and how much detail must be paid to making sure that that process is safe. It's now my pleasure to introduce my colleague, Fred Lublin, who's the director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis, and also the Saunders Family Professor of Neurology at Mount Sinai School of Medicine. Dr. Lublin, earlier in his professional career, was a bench neuroimmunologist. His career has evolved more into the clinical therapeutics arena, and he's widely regarded as one of the leaders in clinical trials and the investigation of new agents and in the design of clinical trials. He is the principal investigator of one of the largest MS-funded grants ever from the National Institutes of Health, doing a trial called COMBI-RX, in which he is leading a study that looks to see whether the combination of interferon and gluteramine acetate or Copaxone is better than either one of those agents alone, a trial that has about another year and a half before its completion. He's served in many prestigious roles in the MS world, including serving as chairman of the National MS Society's Advisory Committee on Clinical Trials of New Drugs, and currently, locally here in New York, he is the chair of the Clinical Advisory Committee of the New York City chapter of the National MS Society. Dr. Lublin's talk today is going to return us to the more traditional area of MS therapeutics, and he's going to talk about current and future therapy of MS. Fred.
Well, thank you, Aaron. And first, let me thank all of you for coming out and spending your Sunday afternoon with us today. We're very appreciative of that. What I'm going to tell you, I can see what I'm doing here. Okay, what I'm going to tell you about today is a remarkable story of the development of multiple sclerosis therapeutics over the last 2 decades. And it is truly a remarkable story that will continue, and I'll tie in much of what you've heard during the course of today, including some of what Dr. Cohen told you. But first, I wanted to tie in more simply what Dr. Finkel was trying to explain to you today about the mind and brain, and give you one philosopher's view of where the brain is in priorities. So beyond that, you've heard a bit about causes of MS. And the reason why I put up this slide showing you the level of our discomfort in not knowing exactly what the cause is, that despite the fact that we haven't nailed down the cause, we have 7 therapies on the market already that alter the course of disease, and a pipeline full of interesting agents. But all of them center around the first potential cause there, and that's the immunologic cause. And so what's very clear in multiple sclerosis is that there's an abnormality of the immune state. And we haven't proven that it's autoimmune. As Dr. Fabian said, we think it is. We haven't proven it, but there's no question that there's alteration of the immune system in individuals. And our therapies have taken advantage of that, and I'll show you how that's done. And so this part you've gone through already in terms of genetics, environment, leading to immune dysregulation and damage. In the treatment of multiple sclerosis, and the reason why we employ comprehensive care is because there's a comprehensive treatment schedule that involves disease-modifying therapies as the treatments that alter the course of the disease, treatments that we employ for acute flare-ups, treatments that we have that enhance recovery from attacks, treatments that enhance function from whatever level you're at, symptomatic therapies, which you'll hear more about, and then there's the issue of neuroprotection, that is protecting the nervous system from ongoing damage, and then repair. And repair is mostly what Dr. Cohen was referring to in what we hope to achieve in the stem cell therapies and some other strategies. And so here we have the simplified immune response in multiple sclerosis. I'm sorry to be the first one to show this to you today. Normally we show this type of slide in the very beginning of the day so you have time to write it down and prepare for the quiz. But in this simplified version, we have outlined the targets of the various therapies that we employ, targets both out in the body, in the circulating blood, in the immune system, and those that are targeted in the central nervous system, that is within the brain, all ultimately hoping to lessen the amount of damage to nerve cells. And that's what we're doing here. And then, so jot these down quickly, because that's the last you'll see of that slide. Dr. Fabian told you a bit about the types of MS, and I just reiterate this to let you know that we treat MS by type because that's how we've studied it. When we do our clinical trials, we pick out specific subtypes of MS so that we have as homogeneous a group of individuals as possible so that the results of the study are understandable and that the conclusions are based on whether you were taking the active drug or whether you were taking a substitute. For the most part, what I'm going to show you is results for relapsing remitting disease. And so one of the exciting things is having to change your slides very rapidly before a presentation. So there's several slides that I had to change just because a new drug has been approved for the use in the United States. And so we now have a 1, 2, 3, 4, 5 categories of disease-modifying therapies, the latest being fingolimod, which we'll talk a little bit more about. So currently, we have these agents, and these are brand new slides that I stole from one of my colleagues, these lollipop slides, so I'm hoping they'll perform nicely. So we have interferon beta-1b, and then beta-1a was the next one along, and you may remember these as beta-seron and Avonex. Next was glutaramyl acetate, almost around the same time as Avonex, and that's Copaxone. After that came mitoxantrone. Mitoxantrone is a chemotherapeutic agent and actually part of a second wave of agents. And also another interferon beta-1a, which had been around longer in Europe but didn't get approved in the United States until a little later, and that's Rebif. And then the last of this group was natalizumab or Tysabri, which was initially approved and then had some issues. We resolved the issue, it was brought back on the market, and now is available as well. And now we have fingolimod, which I haven't added to that particular one yet. And so for relapsing forms of MS, relapsing remitting MS, what you know is the commonest form of MS, we have interferons, we have glutaramyl acetate, we have natalizumab, and we have now fingolimod. And this has been our most successful group story, and I'll show you how that looks now. For secondary progressive MS, in fact, for all progressive MS, we have precious little. So interferon had 1 successful trial, but then 3 unsuccessful trials following that. Mitoxantrone has been used successfully in secondary progressive MS, but has a side effect profile that's been generating more concern in our community, both because it has some long-term cardiac toxicity and also because of induction of what's called secondary leukemia. And the incidence of that leukemia has been increasing over the years from what we originally thought, and that's caused us some concern for use of that agent, even in secondary progressive MS. For primary progressive MS, unfortunately, we have no approved therapies. And we've had several interesting trials of agents for this disorder, but they failed to cure the disease or even slow it down. And we're hopeful that by careful analysis of those studies, we can improve upon that situation. Progressive relapsing MS looks like secondary progressive MS, and we treat it the same way. And then you heard we have this clinically isolated syndrome, which is the first attack of what's going to become MS. And there we have 4 studies that show if you treat individuals at that time, before we really can make a diagnosis of MS, but we're highly suspicious, that you can have a very positive impact on the chances of them not going on to another attack. And so we treat CIS much the same way as we treat the relapsing form of MS. And then this newer characterization, the radiologic isolated syndrome, as Dr. Fabian said, we don't know what to do with this yet. And it's going to be very difficult to figure that out because there's not enough of it around to properly study as we would with the CIS or relapsing remitting, because it occurs haphazardly. It's not something that's planned. It's dependent on who gets a bump on the head and has an MRI scan. So that's going to be a tougher one to solve. And then we have the side effect profiles of our varying agents, which you have to keep in mind, and this is part of what all of us at the center do when we sit down and have a discussion about what's going to be the appropriate agent for you. And the way we approach that is that we think that it's a decision we should be making together, that we give you the information you need, that ultimately you're going to decide what's the best medication to put into your body. And so in addition to going through the effects, the positive effects, one has to look at these side effect profiles as well. So for interferons, you've got flu-like symptoms. You can have effect on blood counts, liver function. You can get reactions at the injection sites. And in some individuals, they can develop neutralizing antibodies, which limit the effectiveness of the medication. For glatiramer acetate, you can get reactions at the skin. There's something called an immediate systemic reaction. And I had one other there. No, that's involved with the skin reactions. The immediate systemic reaction is the kind of flushing, palpitations, anxiety, and tightness in the throat that occur right after an injection in a minority of patients, and it usually lasts seconds to minutes. We think it's because you hit a vein, but nothing ever comes of it. For natalizumab, we monitor liver functions. There's this issue of the brain infection, progressive multifocal leukoencephalopathy in a very small proportion of individuals. There are infusion reactions, and one can, in small proportions, develop neutralizing antibodies. Our latest agent, fingolimod, which we're just starting to roll out, has some cardiac issues in that it produces a slowing of the heart rate in most people after the first dose only. And so you have to be monitored for 6 hours in the office, getting your heart rate and blood pressure checked every hour to make sure it doesn't go down too low. And blood pressure over time can go up with this agent. It can have effects on pulmonary function. It may lower your resistance to infections. We need to monitor liver function, and there is a condition of where fluid builds up in the back of the eye that was seen rarely in individuals. And we'll learn more about this agent, of course, as we gain more experience using it. The exciting thing about fingolimod is it's our first pill, and I'll show you what's in the pipeline beyond that. And then mitoxantrone I mentioned already, the cardiac and the leukemic issues. And so there is a course to multiple sclerosis, but it's an unpredictable course, and I think Dr. Fabian alluded to this too. And so part of what we have to figure out when we are deciding on what therapy is where you are on this course and where we think you will be going. Where you are is relatively easy. Where we think you'll be going is very difficult for us. And in trying to understand what's the best therapy to employ, we need to better understand what's going to happen to you as an individual. And so when we sit down and decide, well, when we see you very early in the course, all the way to the left side of that thing, we would like to be able to say, well, we know you're going to do fine for 10 years, and then you may get into some trouble, so we're going to treat you mildly, and then at some point we're going to switch to something more aggressive, versus you fit our profile for someone who's going to do very badly with disease, and we're going to give you a very aggressive agent very early, up to and including the transplant studies that Dr. Cohen was talking about. We don't have that ability yet. And people guess, and there's some people who think they could prognosticate better than others, but the reality is we don't have it yet, and I'll hopefully have time to discuss with you some ways that we're going to figure that out. The other issue that we have is that early in MS, we think there's primarily an inflammatory phase, And later in MS, and I think, again, Dr. Cohen alluded to this, there's this failure of the ability to repair or to compensate for damage. And that means we're going to have to tailor our therapies over time so that we take advantage of what we think is the primary underlying process of an individual at that point. And this part is too small, don't worry about that. Now, the second aspect of treatment after disease-modifying therapies is acute exacerbations. So most individuals with MS have these acute flare-ups over time, and that's what we best control with our therapies, but our therapies aren't perfect, and so exacerbations still happen. And we treat these primarily with corticosteroids, and we do intravenous corticosteroids for the most part, although we're trying to figure out whether there are better ways of using the steroids, perhaps orally, and we've been trying to work this out for some time, and it's been a bit of a challenge for us, but we hope to complete the studies to figure out whether one can substitute oral steroids for intravenous steroids. And then we hope to do some work in the not-too-distant future to see if ACTH, which is a generator of endogenous steroid that's produced in your own body, might be an alternative or a follow-on if steroids fail. We can enhance recovery in individuals who have had an attack and don't make a good recovery with a technique called plasmapheresis. In plasmapheresis, you hook the individual up to a machine and you take out their blood and you separate it into the cells and the serum. You keep the serum, you throw it away actually, and you give the cells back with a substitute for the serum. And when this is done within a 60-day window or so of an acute exacerbation that made a poor recovery, 40% of individuals will get some form of significant improvement. And so that helps us enhance function. It doesn't work for established deficits. If something's been there for years, it's not going to bring back function. But things that are lost relatively acutely, it will have some benefit in 40%. We can enhance function. We can get people walking faster. And this, again, is a new symptomatic therapy that we started utilizing in a marketed version, an FDA-approved version earlier this year, which is a medication, dalfampridine, which blocks potassium channels. By blocking potassium channels, you don't need to know this, but it enhances conduction through partially damaged nerves. And by enhancing that conduction, it was able to get people walking faster and even moving their muscles a bit more strongly. And so that's on the market. It's dalfampridine or Ampera. We utilize it in individuals with walking difficulties, and we're hopeful that in addition to getting them walking faster, we'll get them walking farther, because that has significant functional considerations for individuals. Now, one of the interesting things that's happened over the last 20 years is that we're seeing a change in the demographics, that is, what people look like in our clinical trials. Now, remember I mentioned to you that reducing relapses has been the major outcome measure that we've looked at for all of our therapies. We've also looked at its ability to reduce disability as well. But here on this slide shows you on the left the early studies from the 1990s, and then the studies during this century. And what's happened are two things. One is the rate of exacerbations that we're seeing in our clinical trials has dropped dramatically. Not just in the people who are getting the drugs, but even in the placebo patients. And so this is a little hard to read, and I can't use the pointer to point out the placebos to you, but I can just tell you they've also dropped dramatically. There's a number of potential reasons for this, which include different types of individuals with MS going into studies now. They have therapies than before, but it's also possible that there's been changes in the disease. And again, you heard from Dr. Fabian earlier that there have been changes in the demographics of MS over the last several decades. The other interesting and very encouraging thing is the difference between the 43% on the left and the 57% on the right, meaning that even though the MS has in general that we've been studying has been better, the treatments have been better, and they've lowered the amount of disease to a greater extent. Even though it gets harder, the better people do. And so we're seeing a new era in therapeutics, but also a new era in responses. Now, on this slide, I've outlined somewhat our pipeline. So everything in blue is something that's been approved by the FDA and that we're utilizing at the present time. The items in green are the next wave of excitement, because those are the agents that are in clinical trials right now, late-stage clinical trials. That is the last step before they go through approval. And of this group we expect to see results over the next 2 years for all of them, including the very bottom one on the right, teriflunomide. So I couldn't change this slide in time, but teriflunomide just last week presented their first phase 3 data, and they had a successful clinical trial. So teriflunomide will be the third successful phase 3 pill that we have. And we'll talk a little more about what's coming along beyond that. So here's the agents that we have at present. We have fingolimod, which just got approved. So fingolimod is a once-daily pill, showed very good efficacy in its clinical trial studies. I told you a little earlier about the safety issues that could potentially happen with it. What's going to be interesting to see with fingolimod as it rolls out, because it's a pill, is how it behaves when we start using it in a larger number of individuals. When it was tested, there was a number of things that showed up that was on the slide I showed you earlier, but there was 2 doses tested, a 0.5 milligram dose and a 1.25 milligram dose. Most of the side effects were seen in the 1.25 milligram dose, and the 0.5 milligram dose, which is the dose that's been approved for use, had a pretty good safety profile in and of itself. And in fact, Dr. Cohen, our guest speaker, was the lead investigator on a study of fingolimod against an interferon, showing that it was superior there as well. In any event, what we need to see now that it's out there is how that lower dose behaves. As it continues to behave as it did in the clinical trials, it's going to be very, very good. But as you know, the more people you expose to a given drug, the more chances you are of seeing less common side effects. And so we'll watch for that. Because we've seen that kind of pattern before. But it is exciting to be able to say to people who don't want to take injections, people who don't tolerate injections, or people who were taking the injections but they weren't working for them, that here's an alternative, and it's a non-injectable alternative. The next one that will get reviewed is a medication called cladribine. Cladribine is a semi-selective immunosuppressive agent that affects primarily types of white blood cells, and it does it very effectively. Interestingly, you only take these pills over the first month of treatment, and then you're done for the year. You don't have to do anything else. Its effect lasts that long. And so that's good in that you don't have to worry about taking the pill necessary every day. The worry, of course, is that once you've taken your month's worth of medication, you can't take it back. And so any problems you have with it or anything you need to add on to it, that medication is going to be there. So cladribine has very good efficacy as well in their clinical trials. Safety is being worked on. The European authorities did not approve it recently because of a small number of cancers that were seen in the development process. It's hard to know whether that signal's strong enough yet, but we're waiting to see what the FDA does with this, and they should give us some kind of answer by Thanksgiving, but our best bet is the answer is going to be they're going to extend the time that they use to review the drug. Another oral agent is a drug called laquinimod. Laquinimod is an immunomodulating agent taken once daily. It's in phase 3 testing right now. They'll have results for us first quarter of next year. Their phase 2 results suggested in proof of principle, that they had some efficacy, and it also had a pretty good safety profile. There's another drug called alemtuzumab, or Campath, and Dr. Cohen mentioned that because alemtuzumab has been used as a conditioning or agent in transplant studies. It's a very, very potent immunosuppressant agent that has been in phase 2 studies in MS and produced dramatically effective results. It's in phase 3 testing now. Our biggest concern with alemtuzumab is the side effect profile because it's such a potent inducer of suppression of the immune system, and what's shown up in the phase 2 studies is induction of other autoimmune diseases, some of which have been of concern. So more will follow with that, but it is, at least by phase 2, very, very effective medication. The other pill I mentioned was teriflunomide, and as I said, they just had phase 3 data, which showed that they were significantly better than placebo, and it had a reasonably good safety profile. They have a couple more studies to go that are also phase 3, but these were encouraging results. You know what? I thought I had another element on there. Let me just go back there. I had one other agent on there which didn't make it to this one. I'm not sure why, and that's an agent called fumarate, or BG12. And fumarate is also a pill. Phase 2 results, it was given 3 times a day. Again, effectiveness was shown in proof of principle, also very well tolerated, and they have their phase 3 program is underway. And so here's fingolimod. Fingolimod works by limiting the ability of lymphocytes to get out of the lymphatic system. So lymphocytes go into lymph nodes and they receive certain signals there and instructions as to what they're supposed to do, that is, what they're supposed to attack, like bacteria and viruses and such. As you heard in MS, they're attacking your central nervous system, and that's something one wants to avoid. Now, normally, if you don't have any control over them, these lymphocytes get out of the lymphatic system and travel to the brain and do their damage. With fingolimod, there's a molecule on those lymphocytes that they need on the surface to get out of the lymph node. And by blocking that molecule, the lymphocyte can't get out of the lymph node, and they stay there. And so they can't get into the circulation and therefore into the brain and spinal cord to do their damage. It's a little analogous to what you see with natalizumab or Tysabri. There's a molecule that's blocked so the lymphocytes can't get out of the bloodstream and into the brain. Here they can't get out of the lymphatic system and into the brain. And this just gives you an idea, if you want to see some data, of the effectiveness of the agent. So to the left is the placebo group, and the number represents the attack rate per year, which was 0.33, which means 1 attack every 3 years. And then in the 2 doses, it takes it down to 1 attack in every 6 or 7 years, at least in the dose that was approved. And then this just shows data for all the other things that it did. And it was successful in all the outcomes that we looked at, including measures of disability. And again, we don't need to spend a lot of time on that. I discussed with you a little bit about the risks involved, which was the slowing of the heart rate, the potential for infections. Anytime you mess with the immune system, there's a potential for infections. Macular edema is what I told you about, the fluid behind the eye that occurs in a small number of individuals. Our indications are that individuals who have diabetes are more prone to this particular complication, and we'll have to take special attention with them. Decreased pulmonary function was seen primarily on testing, not so much by symptoms. And then we talked about liver enzymes and lowering of white count. It's pregnancy category C, and so we do not want individuals getting pregnant on the agent, although we don't know what the effects would be. And the blood pressure we talked about. Malignancy we thought was an issue very early on, but it has not shown up to be an issue in the phase 3 study programs. We're always on the lookout for these anytime we mess with the immune system, but it hasn't been an issue. Cladribine, I mentioned to you, this is, again, an agent that selectively blocks lymphocytes from doing their job. In this case, their job is doing damage. And the phase 3 studies showed that it was well designed to do this. Good efficacy, very good efficacy, as all these studies done. I don't want to bore you with a lot of data, but it had effects on both reducing relapse rate and on disability and on reducing MRI lesion load and such. And so one of the things that we look at, which if you wanted to spend a lot of time on these slides, you'd see, is we look for consistency in that if the agent's going to have an effect, that have effect on multiple things: relapse rate, reducing disability, reducing MRI lesion load and such. And these agents have done all of that. And so that gives us a certain confidence in the consistency of the data. The risks, as I already mentioned, were lowered white count, lowered platelet counts, bone marrow suppression, herpes zoster, shingles, infections of that sort, other latent infections. The malignancy issue is out there, and we're waiting to see what the FDA has to say about that. And it's a pregnancy category D, which is even more of a concern. We don't want women getting pregnant on this agent. Teriflunomide, we talked about, also blocks enzymes in the developmental pathway of lymphocytes. This was their phase 2 data, which I only show you because it shows that this agent could be used as an add-on to existing agents, including studies with interferon and glutamer acetate. And so we'll see as this goes along what they did report last week, although it hasn't been published yet, their successful phase 3 results. And here they are. This was the results. So the placebo group had a little higher, actually, exacerbation rate that we've seen in modern studies, but you had a 31% reduction with teriflunomide, both doses, in relapse rate reduction and a 30% reduction in disability. Side effects were nasopharyngitis, upper respiratory infections, some mild hair thinning, liver enzyme, pregnancy category D. It may actually be an X, we'll see. And contraception controls will be necessary for both sexes. So the third wave of what we have coming up is fingolimod, cladribine, teriflunomide, and this is the order I expect to see in phase 3s. Liquinimod, we should hear about soon. Alemtuzumab's coming along. There's the BG12, so I corrected it in this slide, not the other one, also in phase 3. And another molecule I didn't spend any time on just yet called daclizumab, which is an infused agent which also has immunomodulating properties. So this is an amazing pipeline for an illness that has an incidence of, as you heard, 1 in 1,000. It's generated a great deal of interest amongst pharmaceuticals and biotechs. And part of the reason for that is that MS is sort of a gateway disease, because the therapies that one can employ for MS also be thought about for uses of things like Crohn's disease and rheumatoid arthritis and psoriasis and even type 1 diabetes, because of the immune modulation. And there's characteristics of all those diseases that have commonalities with multiple sclerosis. But on the other hand, the degenerative aspects of MS, the tissue loss aspects, the work that we're doing there also is translatable into diseases such as Parkinson's disease and Alzheimer's and ALS and Huntington's and things of that sort. And the reverse is true as well. The things that we learn from the laboratories working on those diseases, we hope we'll be able to translate into therapies for MS. You heard a little bit about the combination study we're doing, which will answer the question of whether it's reasonable and effective to utilize combined therapies to take advantage of different mechanisms of action over time. And so we've been studying that, and we'll have results in early 2012. But one of the things we're doing in that study is a biomarker study, which is that where individuals coming in are also being looked at for their genetic makeup, both their genes and the way they express those genes and the proteins that circulate in the blood. And that biomarker study will help us to identify individuals who are going to be responders and non-responders to disease. And we also hope that by following over long periods of time, which we are in this study, we'll be able to look at the genetic or protein makeup of individuals early in the course of their disease that tells us what they're going to do over time. To answer the question that I raised earlier is, who do we full court press early in disease, and who do we lay off and say, you're going to be okay for 5 years or 10 years or 20 years because of the unknowns in MS? And so we hope to get those answers. We're starting to look at them now. We'll get more when we finally break the code. And then there's the issue of neuroprotection and repair. And so the neuroprotection has been a difficult issue. We know we need to employ molecules to protect the nervous system, but we don't have them yet. And so this is one of our major therapeutic challenges, because we think to be able to really have a potent effect on progressive disease, we're going to need neuroprotective molecules. There is, at the moment, only one phase 3 trial in progressive disease, and that's with fingolimod. So we need more, and we need more molecules to do that. In terms of repair, you've heard Dr. Cohen discuss the cellular replacement and enhancement strategies that those cells utilize. We're looking at a protocol now that we're probably going to be employing over next year with a different type of replacement cell to try and do the same thing. So it's very exciting to see these studies moving forward, because this regeneration and repair is ultimately what we need to do. If we look at what we've done with exacerbations, with therapies that limit exacerbations to 1 every 6 to 10 years, it's really time to start thinking about what's next. And what's next is both stopping progression and repairing the damage that's already done. So in many ways, we're a third of the way along on what we have. And the answers to how we do this, of course, have come from basic science researchers in both immune function, genetics, environmental factors, which you heard about in terms of vitamin D and smoking and things of that sort, imaging advances, which have let us look at the nervous system in ways we never could, and then, of course, the kind of things that Dr. Cohen discussed with regeneration and repair. So looking forward to the future, the question is, have we done as good as we're going to do with anti-inflammatory agents? Well, we're now looking at changing the metric that we use in studies from annualized relapse rate, which you saw now is very, very low, to something called disease activity free, where we would define success as an individual having no exacerbations, no change in disability, and no new lesions on their MRI scans. It's a very high hurdle, but we think we're ready to start looking at it with this third wave or next generation of agents that are coming along. We also need to figure out for any given individual what type of damage is going on in the nervous system. Do they have just demyelination, or do they have those cut axons? The little green ball that Dr. Cohen showed about 15 times in his presentation on that one picture there with all the pretty axons, that one green ball, which was the cut axon. And because if people have that, we have to think differently about their repair strategy than if they've just lost their myelin. We need to develop more symptomatic, more rational symptomatic approaches, such as we've seen with dalfampridine, and things like that are coming along down the pike. And we have to start thinking not only of how we can limit disease, but also how do we measure improvement? And we have techniques for doing that, and even some therapies that are suggesting that we can improve individuals. And then we're going to start talking about measures of cure. So the cure isn't at hand yet, but we're starting to think about how it is we're going to determine it, and it's going to be a time-based, much as one sees with tumors. It's going to be activity-free, disease-free, progression-free, 1 year, 5 years, 10 years, 20 years. This is where we're going. And that's what's really so exciting about this pipeline that I'm showing you and the future therapies that we're looking at. And so this is what we do. We do it here. They do it at the Mellen Center, and that is to do clinical trials and try and determine how best to move along. It's a complicated process. You heard what Dr. Cohen had to go through to start doing his studies. This is not easy. It's not cheap. But it's well worth doing right, because we can't recommend things to you until we prove they're going to be good for you and that they won't harm you. And so the way we do this is clinical trials, and if you're interested in learning more about clinical trials, there's a bench outside the door there, which has all sorts of information about potential clinical trials, and we're always grateful for individuals who inquire about them, or even better, sign up for some of the clinical trials that are going on. So, in summary, MS is an area of rather intense interest, and there's all sorts of innovative approaches that are underway. We're very excited to partner with anybody, whether it be pharmaceuticals, biotechs, the Department of Defense, the National Institutes of Health, anyone who wants to put some money into studying MS, we're happy to work with them to develop new and better therapies. In less than 2 decades, we now have our third wave washing ashore of therapies. Each one is improving on the other, certainly in the effectiveness that we're seeing. The effect size that grows so have potential risks. So it's getting more complicated. It's getting better, but it is more complicated, and we have to pay attention to a lot more things. And the mechanisms of action that we have now are sufficiently varied that we need to spend a lot of time with you, sit down and say, well, this is the right drug for you, this is the right one for someone else. Maybe you need a pill, maybe you need to stay on your injectables, maybe we need to do combinations and work that out in the future. These are all things that we need to work out in conjunction with you. And at the present time, we still have little for progressive disease. It's our major unmet need, and we're hopeful of getting some new molecules to study that. And interest has never been higher in MS, and for that, we're very grateful, and I think you all should be very grateful as well. And I thank you all for your attention.